Welcome to Community Health Matters. I'm your host, Amy Marsalis. On today's show, we'll learn about access to health care, hospice care, and neck cancers. All of that coming up next on Community Health Matters. From the News Channel 5 network, this is Community Health Matters, sponsored by the United Health Foundation. Yvette Doran is my first guest on the show today with St. Thomas Health Partners. So glad you could come in today.
Thank you. So happy to be here, Amy. Thanks for asking.
Absolutely. I know that St. Thomas is growing leaps and bounds, serving this explosive growth in population in Middle Tennessee that I've noticed myself, all of these new places popping up around town. Tell us about your role in sort of redefining this experience for patients in Middle Tennessee. I know that you have sort of helped establish this service standard for care with so many new people moving here.
Absolutely. You know, it's a multifaceted plan that we're actually blessed to be able to roll out at this point. Nashville, as you said, is experiencing a huge population boom, and with that we have an opportunity to care for more Middle Tennesseans. Just a little bit of history about St. Thomas Medical Partners. We have 102 locations today. We have 4 more scheduled to open this calendar year, and within those 102 locations we actually have 39 different specialties in addition to primary care. So we've addressed the comprehensive total needs of the patient and how to care for the total health of the patient by adding a full complement of those specialists that are needed. You know, you start with primary care as a gatekeeper, and then you move on to whatever you as an individual may need from a specialty perspective.
You had to do a lot of research to get to this point, to identify, look at your numbers at the population who's moving here, and as the population here ages, what the needs are. Tell us a little bit about that process to get to this point.
Well, you are correct, Amy. It is definitely a process, and it has been a multi-year process. We started this journey a little more than 3 years ago, and it began with an assessment. It began with the current population and the projected population, and really where that growth would be. What communities would those new residents of Middle Tennessee actually reside in? And then we took it a step further, and we said, whether we have a footprint in that area today or not, what is the disease burden or the expected disease burden, meaning the most common or frequent diagnoses of the residents who live in those communities? You know, as we have, I mentioned the 39 specialties, but knowing that primary care is the gatekeeper to all health care and really is the captain of the healthcare ship for each individual patient, we had to look at how to balance that. And so the new sites that you mentioned that we're adding are actually the primary care concentration. Now, those are called community care centers. So in a care center, we have primary care in addition to specialties that will be housed under the same roof, embedded in the communities where those patients live or where the growth is occurring. And so that way the patients can go to their comfort and have the access for the care that they need from primary care or specialties within their community.
So in other words, they don't have to travel. Let's say they're out in the Cool Springs area, Franklin area. They don't have to drive downtown Nashville or to the west side of Nashville.
Absolutely. So the growing primary care, 2 of them are in, well, one is technically Davidson County, but 2 are, you know, in the Williamson County, Cool Springs area. We just opened a new location in December on the corner of Aspen Grove and Cool Springs, and then we have one right off of the Old Hickory Boulevard in Brentwood.
Is there a concern in how you reach those who need health care? Obviously, I know you've done your research on that, you know, as you said, over a number of years, but there probably has been a concern that so many people cannot access care due to multiple reasons. What, transportation, education?
Absolutely. You know, when you look at the changing complexion of healthcare, it is changing so rapidly that you have to not only keep up with what happened in the past, but really the new expectations, the consumerism of healthcare, and what those expectations are from a patient's perspective. And so part of that is, how do you reach them? How do you deliver that access? And we've done that at St. Thomas through a couple of means. We've really utilized our ability to access online options, online scheduling, so that as a patient, I mean, we're all busy in our daily lives. So you want care in an area that's close to you. You need it when you need it. And so removing barriers with an online scheduling platform was a first step into that consumerism component that's now part of patients.
It's almost like care on demand, isn't it?
It is. And we actually have care on demand at St. Thomas. You don't even have to leave your home. I think part of that, though, is understanding what location, what is the acuity level, or what's the need. Is it a simple sniffles case, or is it something more severe? So could you, from the convenience of your own couch, could you have care in your own home or in your office? Do you need a walk-in location? Do you need a scheduled appointment for something a little more in-depth? Or do you need a high acuity specialist, you know, to address certain needs if you've been given a diagnosis that needs further care?
So these community centers, if you will, a lot of them, would they have a lot of the same specialists in each one, or would they have various specialists depending on the demographics of that neighborhood?
They would absolutely have differing specialty mixes based on the demographics and the disease burden, if you will, the needs of that community. Some may be more prevalent in diabetes, some may have higher cardiology needs.
Okay.
You know, so we try to match that as best we can with the needs of the patient.
All right, as far as the telemedicine piece of this, because I had interviewed a specialist from St. Thomas about that, and how you're doing a lot of the, you know, via Skype or FaceTime for some illnesses. Is that part of the care as well?
It's projected to be a future part of the care.
Part of it.
As far as the care centers, now we already have the St. Thomas On Demand, which is, you know, for easy diagnoses, or what we call acute care at home. But I think as we move into the changing complexion, as I mentioned earlier, you know, when the payers, the actual insurance carriers, help direct some of that, meaning the authorization, maybe the reimbursement, as some of those things better align, then telehealth will take on a whole new presence. St. Thomas is prepared. All of our new care centers are already hardwired and ready to go when that lever is flipped by the industry.
All right. Do you have any advice on helping to guide consumers how to access the care and to choosing the care that's really best suited for them?
Absolutely. Healthcare is personal. You know, you need to have a great chemistry with your clinician, whether it's a physician or an advanced practitioner, whether it's for something very simple or something more severe. So I would first say that you need to feel comfortable with your clinician. If you've never met them before, you can go on to, at least on our website, stthomasdoctors.com, you can actually search our physicians and practitioners, look at their bio, understand where they went to school, what some of their, you know, specialty services are, see where they're located, what their hours are, and even schedule your appointment with primary care today online.
All right, a lot of helpful information. Yvette Doran,
yes,
thank you so much with St. Thomas Health Partners. Really appreciate this explanation.
Thank you for
having us. What you're doing
us
in this community. Thank you.
Our pleasure. Thank you.
And we'll be right back with more after this. There are so many myths about hospice and the care that hospice provides, and my next guest, Edie Remus, is here to really clear up those myths. Edie, I'm so glad you could come in and talk about Compassus, which is the hospice organization that Edie is affiliated with.
That is correct.
You know, we think of hospice as, okay, it's an end-of-life option, it's at the end of someone's life, and that really is not the way we should be embracing hospice, is it?
No, it isn't at all. Hospice is really about when you can no longer seek that curative treatment, but you really want to focus on comfort, and you really want to focus on the last phase of life, the last journey you want to do.
I love that word you used before we started, yes.
Yeah,
Okay.
it really is an end-of-life journey, and everybody needs to kind of choose how they want to do that. Some people want to really focus on spending time with family, maybe taking a trip, maybe doing things that they had always had on their bucket list, and so that's a great way to look at it, and that's one of the things that hospice really helps people do, is be comfortable during that last phase of life.
I think another misconception a lot of people have is that it's only for people with cancer diagnoses, and that is not it at all.
Absolutely not correct. No, we care for many patients that have cardiac disease, end-stage cardiac, end-stage pulmonary disease, patients that have neuro diseases. Maybe they've got an Alzheimer's or a dementia that has very progressed. And so Parkinson's disease, could be liver failure, could be renal failure. All of those are diseases that people face with different degrees of time frame before their life concludes. And so how do we help them with that journey? What do they want to accomplish?
What is the time, the ideal time, if there is such a time, the appropriate time to bring hospice in to a patient's, a family's life?
Well, what Medicare says is that a patient should have 6 months or less to live. But what's interesting is what we find is that patients who enter hospice typically live longer. And it's because there's support in the home. There's a multidisciplinary team caring for them, the nurse, the social worker, the chaplain, the bereavement, the home health aide, and all of that team can come to the home and care for them. And the home can be anywhere. It doesn't matter where the home is, but we'll care for them there. And so therefore, it's just a matter of making sure that they get the right level of care for what they're needing.
I know that there are some hospice beds in some hospitals where they have a section dedicated to hospice. So why would someone need to go into the hospital, though?
Maybe we couldn't get their pain under control or their symptom under control. Sometimes as the body shuts down, dependent on what the disease is, it can be difficult. So pain might be an issue, nausea and vomiting might be the issue. It could be that they're agitated. Sometimes we find, especially patients who have had World War II veterans, the shutting down of the brain after they've gone through a war can be very different than the way you or I might shut down our body. And so sometimes you need the hospital to help manage those symptoms.
Okay, let's switch gears just for a second and talk about payment. Who pays for hospice? How is that managed and taken care of?
Medicare pays for hospice, Medicaid pays for hospice, and 90 or 100% of all insurances will pay for hospice. Almost every insurance provider will cover a hospice benefit.
With that many organizations covering hospice and insurance, why don't more people take advantage of it when it's so available as well? Like I don't know if I said this earlier, with Compassus, which is one of multiple hospice organizations.
Correct.
So why don't more people take advantage of this?
It's fear. It's afraid of dying. It's people don't want to hear the word dying.
They think it's giving up too.
They do.
Some people, don't they?
They do. And oftentimes what we really want to focus on is what are their goals? What are their goals of care at the end of life? And then how do we make sure that we have helped them achieve them? And get them the support that they need in order to kind of maybe do the things they want to do. Maybe it's a wedding they want to attend. Maybe it's a graduation. We want them to be able to do those things. And getting symptoms under control means that they can.
This involves the entire family, too.
It does.
I would think the whole family needs to be on board.
Yep.
And you're addressing, hospice is addressing the entire family, I would think.
We are. And underneath hospice, we provide support with social worker and the chaplain as the patient and the family are going through the illness. But then we also provide support for 13 months to the family after the death of the loved one. And that could be something as individual grief counseling. It could be a grief support group. And it's all free of charge to the patient's family so that they can receive support dealing with loss after the individual has passed.
It's an incredible service.
It is.
It really, really is. If someone watching today thinks this could somehow help a loved one through this end-of-life journey and the entire family structure, where can they go for help? How do they find Compassus? How do they find you?
So individuals can go primarily to their primary care physician or their treating physician and ask for information about hospice. Compassus, as well as other local hospice organizations, are all easily found. Compassus has the website where you're welcome to go there, and you can look up any location. We have 3 locations in Tennessee for Compassus, but there are many organizations, hospice agencies within the community that are there to help.
You know, God bless the people that work for hospice too, because I know from doing a documentary years ago with a patient, her end-of-life journey, it was really a beautiful thing to watch at that stage of her life and how hospice helped. So thank you for all you do, Edie.
Thank you.
Thanks for coming in and talking about it.
I appreciate it. Thank you so much.
And we'll be right back with a lot more after this. I'm not going to even attempt to pronounce the next cancer that we're going to discuss with my guest, Cindy Lovelace, because it is a mouthful. Neuroendocrine?
You are very good at that.
Okay,
yes.
that's close.
But that is why we call it NET for short.
NET cancer.
NET cancer,
All
yes.
right. And Cindy, you started the Healing Net Foundation out because of your personal journey, and I know we could talk the entire segment about that, but tell me a little bit about your journey to get to this place, to start this organization.
Sure. Well, I was already a breast cancer survivor at the time that I was diagnosed with neuroendocrine, and my tumor was found incidentally. It was kind of a providential situation. I had developed blood clots because of a reaction to a drug that I was taking with my breast cancer therapy. And as a result of that, the blood clots, I went to the ER, and when I was diagnosed and they did a scan of my lungs, the technician just happened to note down in the lower corner of my scan that they saw a shadow. I followed up with my oncologist, and several months later, they actually diagnosed a neuroendocrine tumor. And they did this through an endoscopic ultrasound. And it was found in the tip of my pancreas. It was pretty amazing that they even found the tumor.
You had no symptoms.
I had no symptoms whatsoever. And as a result of that, I assumed there would be a protocol for neuroendocrine cancer. And what I found out from my oncologist is not only was there not a standard protocol, but she actually didn't know very much about the cancer because it was considered so rare. And I had it resected, had a really great surgeon, and I was doing well. And then in late 2011, I was watching CNN News with my husband, and the story came on that Steve Jobs had passed away. And Dr. Gupta with CNN went through this whole process of explaining that Steve Jobs had neuroendocrine cancer.
And you were floored.
I was floored. I was shocked. I Googled it again, not like I didn't before. But this time, the first person to come up in my search was a doctor at Vanderbilt, Dr. Eric Liu. And he had started a neuroendocrine center. And I couldn't believe it. And I said, what? There's a doctor right here in Nashville, Tennessee that knows about neuroendocrine. Turns out he and my oncologist were good friends, but she didn't understand what he was doing, that he was a surgeon that did neuroendocrine. And so that was the odd, 6 degrees of separation there of not, having that connection to know that there was an expert in the disease. And so when I went to see Dr. Liu, he was able to explain to me so much about the disease, and had also trained in Sweden and had started a clinical trial at Vanderbilt for the first gallium-68 scan in the United States.
And that's how they're tracking them?
Well, this is a new diagnostic tool. It was this was in 2011. It's now been approved by the FDA in 2016, and it tends to light up these tumors that other scans miss. In my case, I had an MRI on my liver, which showed that it was clear. But when I took the gallium-68 scan, 2 tumors lit up on my liver. And so I never would have realized this had it not been for that diagnostic treatment.
So what was the next step then? What was your treatment after those tumors lit up? What did they do?
I did have one resected. The others are watched. One of the things that we've learned about neuroendocrine cancer is that, it tends to be a lifelong management of this disease. You can resect, but the tumors have a tendency to pop up in other places, or more tend to grow in the area. And so now I'm in a watch and wait. I do take a medication once a month that will help slow the growth down even more. They're slow growing tumors, which is a good thing, but also because they're slow growing and can be so tiny to start, they're hard to detect.
And people are often misdiagnosed, you said.
They are, and the misdiagnosis comes in more with people who are symptomatic. Now, I had no symptoms of the disease, but people who are symptomatic have really life-altering symptoms. They have chronic diarrhea. They may have flushing, where they feel really hot and their face turns red. They may have a pain, an unexplained pain. They may have some wheezing that could be attributed to asthma. So a lot of people are misdiagnosed with Crohn's disease or IBS or IBD, and the average time for correct diagnosis, unfortunately, is about 5 to 6 years.
Oh my goodness.
Because people are trying other medications to try to solve those symptoms.
With all these digestive-related, almost bowel-related, intestinal, is that where a lot of the tumors live?
Yes. So this is a cancer of your hormone-producing cells. And the majority of your hormone-producing cells tend to be in what is called your gut region, your digestive area. And so typically the pancreas, the stomach, your small and large intestines, your mesentery, and then can also metastasize to the liver, as in my case. But then there's also patients who have these in their lungs. And that's where you get into the wheezing symptoms and difficulty in breathing, that sort of thing.
Do many of them start in the lungs or metastasize to the lungs?
Some primaries can be in the lung, yes.
Primaries can be.
Absolutely.
About how many new cases are there? Since it is still considered rare, how many cases do you see a year?
Well, there is some concern that they may not be all that rare because the incidence is rising. The latest study shows that about 7 in 100,000 cases, about 171,000 people in the United States diagnosed with the disease. But what we're concerned about, particularly at the Healing Net Foundation, is because so many physicians are not aware of, don't think about neuroendocrine tumors when they have a patient who is showing all these different symptoms, or even when a tumor is found incidentally. So they may not be aware. So there's a lot of people that we feel fall through the cracks and don't get properly diagnosed.
Well, we're so glad that you are here to share this with us, that you're doing so well, and glad there's the Healing Net Foundation. Thank you so much.
Thank you.
We really appreciate it.
Thank you.
And thank you so much for watching Community Health Matters.